Boas-vindas a todos. É grande privilégio estar hoje entrevistando uma das grandes lideranças mundiais da cardiologia intervencionista que está no Brasil, visitando a comunidade brasileira como parte das atividades relacionadas ao Congresso Mundial de Cardiologia, a doutora professora Roxana Mehran, que trabalha em Nova York, no Hospital Mount Sinai, é uma das líderes também da Cardiovascular Research Foundation, uma das organizadoras do TCT e uma das lideranças talvez com mais contribuições científicas na nossa área. Roxana, what a privilege to have you in Brazil.
Thank you.
On behalf of the Brazilian Society for Hemodynamics and Interventional Cardiology, we want to take this opportunity to hear a little bit about, your thoughts about the science in our field and the way things are going now. One of the things that we are seeing that so many evidence in the recent years in regard to the antithrombotic therapy, and I'm speaking mostly in terms of coronary, and especially when we deal with high bleeding risk patients, even with all the evidence and the guidelines, we still see a lot of challenges with that. So where do you see are still, the challenges, the new trials to come? What are the parts that need to be filled still?
First of all, I want to thank you, Professor Costa, Mr. President. It really is a privilege for me to be here with you and to talk to the community at large in Brazil and to the world about what's going on in antithrombotic regimens. I mean, I think what's incredibly exciting about our field in interventional cardiology is that we continue to evolve and we are never at rest until we get more and more evidence. Our work is always based on the evidence and the clinical trials that we design, and we try to answer questions that matter to clinicians, but most importantly, in quest of the best possible outcomes for our patients. And as the procedures have evolved with improving our devices, our technology, all of the imaging, all of the fantastic work that we now have done in improving the safety and the efficacy of our procedures, we're seeing more and more complex patients. And complex patients come with multitudes of risk, especially high bleeding risk. And this kind of puts us in a conundrum on how we could manage and balance the risk-benefit for our patients, where we know that antithrombotic regimens are associated with reducing ischemic risk, but at a price of increasing bleeding. And so in the high bleeding risk patient, it gives us an opportunity to do our very best job in the cath lab with IVUS or image-guided treatment, but also physiology-guided treatment to get the best possible result in the lab in terms of best stent expansion using physiology-guided and ischemia-guided therapy, improving and enhancing our background medical therapy of our patients because that's also evolved. And the technology of stents are just so fantastic now that you really are able to treat the most complex patients. But in high bleeding risk patients, we're also, because of the fact that we've done so much of a great work in enhancing and reducing ischemic complications, we can shorten the antiplatelet regimen duration, especially for dual. And in our single antiplatelet regimens, we also have choices in dropping aspirin, going to a P2Y12 monotherapy, and also we have both genetic testing and platelet function testing that we could enhance in making sure for highly specialized patients that we have the best possible treatment going forward. So the future is very, very strong in terms of where we are. And I think that the future research is going to work a lot on personalized approach for these patients because not one size fits all. And we're learning, I compartmentalize into 4 quadrants, but of high bleeding risk and high ischemic risk, low bleeding risk, low ischemic risk, high bleeding, low ischemic, high thrombotic, low bleeding risk. You could do that in a quick way, but it's even more to it than that. And within those categories, you can do more precision medicine. So it's all about how we're going to approach this. And I think future trials are going to be much larger, are going to answer questions in a pragmatic approach, and are going to be very much patient-centered for quality of life for our patients, which endpoints matter. And I think in terms of antiplatelet, antithrombotic regimens, the one big question is what should be our chronic maintenance therapy? Should it be aspirin indefinitely or a P2Y12 monotherapy? And if it's P2Y12 monotherapy, which one? And when do we de-escalate from a potent to a less potent? When do we test? All those things are up for grabs in terms of questions to be answered. So it makes it exciting for me as a clinical trialist who starts to think about these questions for future trials.
And now moving towards medical education, what we are seeing in the recent years in our field, it's moving very, very fastly and strongly to structural heart disease. And like TCT this year, we saw like most of the novelties in the new trials are in the structural field. How do you see the core curriculum for medical education for fellows and the role of societies into that, as we should add more years for that, or how people will be able, and physicians, new physicians will be able to perform in all of these fields, or would we subspecialty will become more subspecialties more than a specialty itself?
No, I think you're very right. I think even in coronary intervention, we are seeing some further subspecialization in treatment of like multivessel disease and bifurcation stenting and high risk, what we call complex high risk procedures, where there is advanced fellowship there, and also for hemodynamic support and large bore access, and those things require more training. Calcium, treatment of calcium, those require more training, more hands on deck. And then on the structural side, it's a booming new area that is no longer new. TAVR is 20 years old, and we're now moving into multitudes of valves. We are now even moving towards heart failure intervention. We're going to be using atrial septal, performing an ASD, basically making an ASD for HFpEF patients, the no implant shunt that we're putting in. So these become highly subspecialized. So it's not just getting a 1 year of intervention and you come out and you can be doing left atrial appendage closure, atrial septal defect closure, TAVR and mitral and tricuspid and pulmonic valve intervention. Those all require a lot more training. And I also believe that even within that, you have to, as if you're going to be a structural interventionalist, you have to learn echo. You have to understand imaging. You have to understand CT. So all of that requires more training than what we've had in the past. So education becomes seminal, and the societies have to think about, what does this really mean? How much longer can physicians keep training? When do they actually start to go into practice? If you think about, for us, I thought it was a very long time for me when I did 4 years of medicine, 4 years of cardiology, in terms of 3 years of cardiology, 1 year of intervention, and then another year of like high IVUS and OCT training. That's a lot already. That's many, many years. And we have to also be careful that we balance this extra training with what physicians are looking for. So in my mind, I think what you could do is to make that physician an attending at the end of their interventional training for coronary intervention, but give them the opportunity to train further in structural, so they could do both and learn in that way if they want to do structural or if they want to be more advanced, and then highly subspecialize them to keep them as a fellow forever, 6, 7, 8 years. You're going to deter the talented individuals to want to come and do cardiology. At the end of the day, everyone has a family, man or a woman, and they need to get to their families and to making money and supporting them. And so we have to make them into adults at some point. They can't always be students. So we need to make those important balances in terms of how do we think to expand cardiology and interventional cardiology and structural heart disease in a way that attracts more people rather than deter them from us. So training can continue. And I think to myself that we have a lifelong learning. As a member of the Board of Trustees of the American College of Cardiology, as you know, ACC is completely committed to lifelong education. And so should all societies be thinking that way, that in that lifelong learning for a physician that continues to be updated on their certifications, but also in understanding the new technologies, that will require more and more training and that constant learning that never stops for all of us.
You have been a great leadership, exert a great leadership for the Women Initiative throughout the world, for equality of opportunities, but also calling the attention for the underrepresentation in clinical trials as a, let's say, a complex and high-risk subgroup in many aspects. We still see that a lot. How can we somehow try to balance this in a better way in terms of a better representation for clinical practice and clinical evidence for what we do?
Yeah, so there are two parts to this. So one is in treatment of women with heart disease, where women are underdiagnosed, undertreated, underrepresented, and ignored for their symptoms, for their just even guideline-directed medical management of women with cardiovascular disease. It's the number one cause of death in the world is cardiovascular disease. And we have to, it's both in men and women. And I always say no woman should come to a cath lab with a chest pain syndrome and leave without a diagnosis. If you haven't done microvascular function, all these other things that are unique to women. The problem is that our education is not really focusing on sex-specific differences between men and women, and it is constantly comparing them and imagining that women are small men, and we're not. We have biologically different. We have different prevalence of valvular heart disease, different prevalence of heart failure, different prevalence of kinds of heart failure we present with, as well as coronary disease. And as a whole, we need to have a better understanding. And of course, this means more representation in clinical trials. Almost every device and every drug that's been approved, it's really for white men. We do not have the diversity in the population in the clinical trials to translate them to the population of the world. And it's an unfortunate situation that we must change. And we have to stop talking about it and start the action. And so through the Lancet Commission that I led, we came up with the top 10 recommendations. And in this last year, since 21, this was published in 21, we focused entire year of 2022 on education and awareness. It was the year of awareness. And the next 2 years, we're going to be designing clinical trials in women for women. And so we're working on that, and we will be doing that. We have to go where the patients are. You cannot sit in your ivory tower and imagine that all these patients are going to come to you. We know that primordial prevention is lacking in underrepresented minorities and in women. And we absolutely have to pay an important attention to that. But then the other side of the coin is that while the medical students in medical school are more than 50% women now, in internal medicine, 48% are going into internal medicine. But when it comes to cardiology, there's only about 20% in the United States are female cardiologists. In interventional cardiology, that number dwindles down to under 10%. And if you go 5 to 10 years into practice, you start to see even less, under 5% in interventional cardiology and under 15% in cardiology. And we also know that there is an important association in a woman being treated by a woman in terms of, or a black man being treated by a black doctor, where there is this sex and race concordance that helps in the medical management and in the treatment of those patients. They have better outcomes. But we do not have enough women in cardiology, or especially in interventional cardiology. And we know that there's important discrimination, pay gap, harassment, microaggression, and toxic work environment that is present for underrepresented minorities, but especially for women. And that must end today and now. And so the foundation that I founded and launched in 2019, Women as One, is completely focused on that. It's focused on finding and matching talented women to important professional opportunities and in enhancing their professional life. And when it comes to, women in the professional work environment and the family life, I do not want to hear that is a difference between a woman and a man, and that we must be thinking in a partnership in terms of the work-life balance, because we also hear loud and clear that men want to have time with their family too. No man goes to their grave wishing they worked more. They want to be more with their family as well, and they miss out as well. And so we need to think about our subspecialty to be more family-friendly, to be more inviting, to be more inclusive, to be more equitable, and to be more accepting of other than the white males that predominantly dominate our subspecialty. And the way we're going to do that is in really making a structural change that is intentional and that it is well-planned and accepted by all. The naysayers will have to leave us. We cannot have an environment that discriminates against a certain race or gender. And we have to be very, very open and honest and bold and intentional about it. And I'm sure that the future is extremely bright because we realize this problem exists, we've owned up to it, and now we have action plans to make those changes.
I now, lastly, would like to give you opportunity to address a message to the Brazilian community of interventional cardiology. You have a lot of friends here. You are very admired here. So please, if you can address that.
Yes, first of all, Brazil is one of the most beautiful countries on earth. Aren't you all so lucky to come from this fantastic, beautiful nation with so much to offer? It is also gives you an incredible opportunity to learn, to discover, to be proactive, and to be out there in practicing medicine and helping all mankind. This is one of the most diverse nations in the world, with the most diverse pathology, especially with cardiovascular disease. Cardiovascular disease is the #1 cause of death in Brazil, even with all of the communicable diseases that exist here. Still, it is incredibly important. The social determinants of health play a very, very important role in how patients are treated and how we can make an impact in improving the human health that exists here in this nation. You, as cardiologists, have a front and center and incredible role in reducing the cardiovascular burden of disease globally, because if it's reduced in Brazil, it could make an important impact around the world. And I really applaud you for all of your enthusiasm and your energy and your love for cardiology and for cardiovascular disease, for continuing your education and your lifelong learning to enhance and improve human health by reducing the #1 cause of death in your nation, cardiovascular disease. So thank you for all of the work that you're doing. Keep up the great work, the enthusiasm, the love for your people, and the love for human health, and the love for caring for others. You are an amazing, amazing nation. And I just love this country, and I can't wait to come back and visit you all once again. I look forward to the World Congress of Cardiology and going to Rio and representing the American College of Cardiology, but also representing America in that World Congress is going to be extremely exciting for me. And I look forward to seeing you all and continuing the collaboration. So keep keep up the good work. You guys, your clinical trials are fantastic. Your sense of enthusiasm and love is really, really almost infective and contagious. And so I love it. And I love to come here and be energized. So thank you for your attention and thank you for listening.
Thank you so much.
Thank you, Dr. Costa. It was really such a pleasure to be here with you. Thank you.
Thank you.